Hello, hello. I am so happy to be back in California. As you can see, it's nice and warm today. Last week we were in Denver, which was actually quite beautiful and not that freezing cold. But back home, back at our clinic, and I actually hope that you can overhear what is happening right now because it's our reburn cardio class. Bunch of people working out and they're doing all of these brain games at the same time, and it is like music to my ears. So if you overhear people shouting out different states while they're exercising, that's what's happening here. So welcome. My name is Julie Hirschberg. I am a neurologic physical therapist here at Re+active, and we are an outpatient physical therapy, occupational therapy, fitness, yoga practice for people with neurologic disorders. And we're the home to the Schmidt Movement Disorders Fellowship, which as of yet is the only fellowship program in the neurologic field. And as part of that fellowship program, we do a lot of education where we dive deeply into things movement disorders. And coming up next week, we are doing a course on advanced movement analysis in movement disorders. And so this is a little bit of a preview and some of the big pieces that we have studied and read about, especially in the literature leading up to this topic. So the big take home from what we're talking about today is really how to get the most bang for your buck out of analyzing movement. And today, especially a very simple task of turning in Parkinson's disease. So last month, I actually brought mine here today. Last month, the JNPT, the Journal of Neurologic Physical Therapy, this was in January 2020. They had a very lovely article entitled Differentiating Parkinson's Subtypes Using Clinical Balance Measures. And they highlight the use of the 360-degree turn. And I love doing this test for movement analysis. And it turns out it helps differentiate Parkinson's disease subtypes. So I adore any test where we can get 2 for 1 like that. So we're gonna review a little bit of the article. We're gonna discuss how advanced movement analysis helps with differential diagnosis and with our treatment at the same time. How to look at a 360-degree turn for differential diagnosis. And then how watching the biomechanical components of it leads to treatment. So that's a lot, but actually it's so simple because it's just looking at turns. So I want to start off with a worksheet and I'll post a link to this. So this is a worksheet we've been going through the past few weeks as we talk about advanced movement analysis. This is something that we developed when we first developed this course as an easy step-by-step way to help figure out what is that? Is that a tick? Is it a tremor? Is that dystonia that I'm seeing? So how to figure that out, how to classify it, but at the same time, so we have the differential diagnosis part, at the same time, actually analyzing movement in a biomechanical way to lead to treatment so that we can get both of these things done at the same time. So differential diagnosis and leading to treatment. So this is the worksheet we've been talking about for the last through few weeks, probably about 3 weeks. So we're going to talk a little bit more about the biomechanical piece today, but because of this really great article, it actually pulls in the differential diagnosis. So in this article, by the way, the lead author was Morgane Prime, I think, from France, but a group of people from Georgia, including Emory University and the VA there. So in this article, they were looking at how to differentiate between the 2 subtypes of Parkinson's based on some of the common measures that we do as physical therapists every day. So my first question, and maybe you're wondering this if you're not in the field of a lot of Parkinson's, did you even know there were subtypes? So I certainly didn't know that until I dove pretty deeply into the movement disorders world, maybe 12 years ago or so. So there are two main subtypes of Parkinson's. One that is more tremor dominant, they call that TD. So tremor is the big dominant symptom. And one that is postural instability or gait instability, where those are the dominant features, and they call that PIGD. And so in that PIGD form, there is the bradykinesia that we typically see, the rigidity, and maybe a little more of a balance problem. And in the tremor dominant, the resting tremor is very dominant, but the gait dysfunction is a little less of a problem. So there are these two types, and right now they're usually categorized by the UPDRS, which is the standard test that a movement disorder neurologist would do, that looks at all the components that underlie the symptoms of Parkinson's, and that actually helps discriminate between these two types, and it's the gold standard. But in this article, the authors wanted to see also if some of our quick functional balance tests could do the same. And so essentially what they found is that, well, first they looked at the 360-degree turn, they looked at tandem walking, single leg stance, and a reactive postural control. And they did this with 104 people, so it was a pretty big group. And their results are really interesting to me. So most significantly that they found, it was the number of steps that it took to turn 360 degrees that helped discriminate between the two types of Parkinson's. So between the tremor dominant and the postural gait dominant type. And they found a cutoff value of 7 steps to take to do that 360-degree turn that had a good sensitivity. And then, but they found that a cutoff of 10 steps had a good specificity. So they actually, by the end of the article, gave a couple of scenarios where you could use either one of those cutoff scores. The time also was significant. So the time at greater than 5 seconds to do the 360-degree turns was very specific. Again, differentiating that postural and gait instability type of Parkinson's. So isn't that interesting? I think it makes sense if you're having more balance problems. So one other thing that they found is that they had a subgroup of people that were earlier on in Parkinson's, and they found very specifically that that cutoff score of 7 steps and then an even shorter time, so 3.67 seconds, was more discriminative in early Parkinson's. And I think this is so interesting for many, many reasons. So one of the biggest reasons is we just did a whole cohort of 20 people who were newly diagnosed with Parkinson's, and we had funding from the Parkinson's Foundation to do a really thorough testing and treatment with them. And we use the 360-degree turn. So we can really compare our data with this and these cutoff scores to see if that holds true in our population. So I'm very excited about that potential for analyzing this data. Now, second, and really what we're talking about today, is can we then use something like turning to help with our differential diagnosis? Yes, so according to these authors, we can use this to help us discriminate types of Parkinson's. So if we do a 360-degree turn and we're wondering if this person is more in the tremor dominant or the postural and gait instability dominant, we can use the timing of it and the number of steps to help piece that out. I personally also love components of the UPDRS that I would do as well to look at rigidity and bradykinesia and pieces of that. So I would put all of those pieces together to help with that differential diagnosis. So hugely helpful. We're doing it anyway, and now we can use it for another means of understanding what's happening for this person. And then from the biomechanical standpoint, we could use our biomechanical movement analysis skills to really look at that turn. So this is not what the authors did, but there's been several other studies looking at this. And I would look I would argue that you'd want to look at the turn, count the number of steps, time it, and I like to video it so I can slow it down and watch it and really analyze what's happening biomechanically. So I'm going to give you a little sneak peek at what we're going to talk about in our course next week. And how we do this. So in particular with turning. So turning is a movement that a lot of people end up freezing or even having falls with. So this is a very important one. So there's a really wonderful article that we use in the course, and I'll put a link to it as well, where they've looked at this specifically in Parkinson's, looking at the biomechanical analysis to see what components tended to make people more likely to freeze. And there was a couple of key events. One, people were less likely to freeze when they initiated the turn with their head. And so I actually had my whole group of students at USC in our neuropathology class do this yesterday. I said, okay, let's stand up, turn around. What leads the turn? What comes next? What happens? And then I said, well, now try to do it and don't turn your head. And how does the turn move? So the turn should be initiated with the head, and that's very goal-oriented. Where are you going and what are you doing? Second, the trunk should be rotating, following the head. And then finally, the pelvis. So one key piece of this article is that when there was pretty severe freezing, this sequence did not occur. And one of the biggest pieces is that the head turn didn't occur. So could we potentially decrease freezing by helping someone gain range in their neck or just start their turn with their head? I would argue absolutely. Very simple biomechanics. Now, we know freezing is complicated, and there's definitely cognitive pieces of that, but these biomechanical pieces can be addressed usually quite simply. So I've done things like improve somebody's range of motion, have them use it with their turn, and by golly, they're not freezing anymore. And then of course, we need to practice that, right? So typically we can address that biomechanical part, and then I need to layer in pieces to drive that automatic movement, layer in the dual task, layer in a distracting environment and all of those things. But we can take what we understand, what's been shown in the literature about normal turns, number of steps, the timing of it, the biomechanics of it, and drive that straight into our treatment and make some changes within seconds for people. And I found that very, very powerful. So that is a sneak peek. We're going to actually do this with cases in our course, analyze the movement, come up with some ideas of treatment as well. And we're going to use this framework. So we're going to go through characterizing really odd movements. So we're going to watch a lot of videos, characterize those movements, and then go, okay, but we also need to treat people. So biomechanically, are there pieces where we can intervene as well? So I love this stuff. I love differential diagnosis. I think y'all know that about me. I love the Nancy Drew of physical therapy. So we get to do both of it in our course, and this was just a sneak peek for you today. So certainly if you want to join us, our course is next Thursday. It's called Advanced Movement Analysis. I'm going to link to these articles because they really changed some of the ways I was thinking about practice, and I'll also link to where you can download this framework if you're interested. And thanks so much for joining me, and please catch us next week. I'm bringing on one of our physical therapists, Amy Nair, for Rare Disease Day. And if you are a neuro-PT, you are often seeing some very rare diseases. We see a lot of them here, but in particular, we're going to talk about some of the connective tissue disorders and MCAS, because this is where Amy is a just real expert, and we're so thankful to have her here. So join us next week for that, here, Friday, 12:30. Thanks so much.